Hello everyone, this is Dr. Mahesh Malu from the coastal town of Andhra Pradesh, Visakhapatnam. I am presenting my paper on the topic Decoding the Osteoarthritic Puzzle, MRI-based MOOCs as a bridge between structures and the symptoms. Co-author for my paper is Dr. KJS Raghuteja, Professor, the Department of Radiodiagnosis, Gynaec Hospital. Osteoarthritis has a long, harbored one of the most enduring riddle in the musculoskeletal radiology and clinical orthopedics, the structure-symptom discordance. What I mean by it is for decades, the physicians have routinely encountered the radiographic illusion. What it means, the patient with profound joint space narrowing, rampant osteophytosis, but the clinical wise, the patient come to the clinic pain-free. While alongside those, there are structurally pristine normal radiographs suffering from the debilitating knee pain. This stark disconnect exposes the fundamental diagnostic blind spot. It highlights the flaw in viewing the osteoarthritis through a purely bone-centric radiographic lens, which completely ignores the soft tissue architecture, cartilage, synovium, meniscus, and the marrow pathologies, orchestrates the disease's true clinical pathology. Today, we recognize that osteoarthritis is not merely a focal wear and tear disease of articular cartilage, but a complex, heterogeneous failure of the entire joint organ. This paradigm shift was catalyzed by the advent of MRI, which inbuilt the silent, non-osseous contributors to the osteoarthritis cascade. Yet, while MRI provided the high-resolution canvas, the radiological community needed a standardized language to accurately interpret it. So there comes a role of MOOCs, that is the MRI-based osteoarthritis knee score. It has developed from the refined, developed, synthesized from the various of the prior semi-quantity scoring system like worms and the blocks. We will discuss about this in the coming slide in the further. MOOCs provide a granular multi-tissue assessment of the osteoarthritic knee. It meticulously grades everything from the depth of the focal cartilage loss to the volume of the bone marrow lesions and the extent of the Hoffa's synovitis. However, while MOOCs has become a cornerstone in the epidemiological research and clinical trial, its ultimate potential acting as a definitive translator between the anatomic degradation and the patient-reported pain remains a puzzle. And this paper focuses on solving this puzzle. So the method of the study is, it is a cross-sectional analysis which was conducted on patients, 120 number of patients presented with a chronic knee pain referred to the Gynaec hospital over a period of 9 months. Diagnosis of rheumatoid arthritis, gout, pseudogout, septic arthritis. These patients were excluded. Second, the recent acute trauma or the surgery. Any history of major knee surgery on the knee index joint, ACL reconstruction, osteotomy, prior partial mastectomy, or acute trauma within the last 6 months. Confounding intra-articular treatment. Patient who have received intra-articular corticosteroid, hyaluronic acid, or biological PRP injections in the knee joint in the preceding 6 months were also excluded. Neuropathic pain condition, presence of severe lumbar radiculopathy, peripheral neuropathy, because that could confound the patient reported lower extremity pain indices, and the other standardized MRI contraindications. So what is knee KOO score? It is a knee injury osteoarthritis outcome score. It is a questionnaire with a Likert scale, and which was in the recently officially published, but we have translated into a vernacular language in the Telugu, and the similar questionnaire was asked. It designed to assess the 5 outcomes, that is a pain, symptoms, activities of daily living, sports and recreation function, and the knee related quality of life. So if it's there are multiple questionnaire, like if you start with the pain, it will have a particular 9 questions. How often is your knee painful? Is there twisting, pivoting on your knee causes the pain? Whether straightening knee fully causes the pain, bending causes the pain. While if the answer is no, it is taken as 0, while the others, mild, moderate, severe, and extreme is 1, 2, 3, 4. While the 100, the top score will represent the perfectly normal knee, while the 0 will towards the decline of the function. Similarly, is for the symptoms, how severe is your knee stiffness after waking in the morning? Do you have swelling in your knee? Do you feel grinding, hearing, clear, clicking sound, or any other type of noise when you knee? So it assesses the multiple symptoms and the clinical profile. Radiograph of the knee joint. The features described, which is shown in this, are osteophytes, asymmetric joint space narrowing, particularly indicating the medial compartment. And the third is the subchondral sclerosis, which we can see. Similarly, we can see in the figure 2, there are prominent osteophytes and the similar asymmetric joint space narrowing. So in this total 120 cases, the Kellgren's-Lawrence score, as it features the 3 prominent features. The first is the definite osteophytes, second is the joint space, asymmetric joint space narrowing, and third is the subchondral sclerosis. It has a multiple component. The first is the synovitis effusion. It's graded from whether it is retropatellar, then there is suprapatellar, whether there is extension, while the grade 3 indicates the capsular distension. Also, the grading is for the meniscal extrusion, right from 2 to 3 mm, 3 to 5, and the more than 5 mm. While the bone marrow lesions, articular cartilage, and the osteophyte, these are the primary, and they are divided based on the multiple subregions. So the primary subregions for the patella are the superior, inferior, medial, and the lateral, while for the femur it is divided into anterior compartment, that is trochlea, central femur, and the posterior, while for tibia it is divided medial and the lateral. And the bone marrow lesions, these are the ill-defined, hazy, hyperintense, which they are classified based on the volume of the subregion involved, less than 33 to 66, and the more than 66. Similarly, the cartilage loss as a percentage of the total area region, right from the less than 10% to the more than 75%. And this all collective scores is a main reporting template which we to be described. The subregions of the MOOCs, which we had said, so the femur is divided into 3 compartments: anterior trochlea, middle, central, and the posterior compartment, while the patella divided into medial, lateral. So the images, a few of the references images with the description. This image, axial PDFS, coronary T1 FS E sequence, sagittal T2, and axial PDFS showing a bone marrow lesion. This is most of subcondylosis. This is a chronic phenomena involving less than 33% in the lateral tibial plateau adjacent to the anterior root site of the lateral meniscus. While in the figure 5, we can see there is a moderate joint effusion with the synovial thickening. While the image figure 5b, we can see there is a meniscal extrusion. So figure 6.8, it describes the axial PDFS, right knee showing the cartilage thinning and the fissuring involving more than 50% of the region of that particular area. While figure 7.8 describes the front leg synovial thickening with the mild joint effusion with the extension in the suprapatellar compartment. While the figure 7 this is described showing multiple marginal osteophytes involving the femur anterior compartment, that is as well as the superior and the inferior pole, while the superior pole of the patella, and the multiple other subregions of the femur, which we can see here. So the results coming to the statistical analysis, the bivariate correlation analysis, MOOCs versus the COOS, to quantify the relationship between the structural degradation and the clinical symptom burden, Pearson's correlation coefficient were calculated. So the conclusion is the statistical mapping, it provides that the maximum parameter which contributed to the pain, it was synovitis effusion, followed by the bone marrow lesion, which we can see in these values, followed by the meniscal damage, and last was the cartilage loss. Conversely, cartilage defect, despite their 92% prevalence, they showed only weak to moderate correlation with the actual pain manifestation, while the bone marrow lesions and the synovitis effusion, these are the maximum contributing to the pain. So how it can be useful? Because the treatment modalities, if it's synovitis, which is causing the maximum pain, the treatment should be focused on that, right from the intra-articular corticosteroids to the NSAID. This will have that while the managing regarding the synovitis. While the bone marrow lesions extensive, it will have the surgical management options only. While the other management option which we see are the emerging are the PRP, hyaluronic acid. These are mostly for the fissuring defects in the cartilage and the cartilage loss, which can anchor the joint properly. While the most commonly discussed osteophyte, these have very least role in the pain, but it has a maximum role towards the restriction of the mobility. While the other feature which we usually describe in the radiograph is the subchondral sclerosis. That parameter, it is primarily focused on the chronic pathology rather than the acute symptom. So this kind of division based on the symptoms and the MRI findings can actually yield a good outcome for the patient. So understanding, so this study seeks to bridge that critical gap by decoding the intricate relationship between the specific MOOCs variable and the dynamic symptom profile. MRI can transform from an observational diagnostic tool into a predictive clinical compass. While the understanding the structural symptom bridge is an urgent imperative which we can pinpoint, ultimately ensuring treating the patient pain rather than just their scan. Thank you for this opportunity.